Hello, I'm Harry Crijns and we are here at the European Heart Rhythm Association's Congress to present the results of the wait and see versus acute cardioversion trial. I'm here with Elton Dudink and Nikki Pluymaekers, who are the doctors who were the backbone of our trial. I'd like to ask you, Elton, the rationale of the wait and see versus acute cardioversion study, why did you do that?
So atrial fibrillation is a condition that terminates simultaneously in most patients. And however, if people come to the emergency department with an episode of atrial fibrillation, we choose to do a cardioversion, so either pharmacological or electrical. And that doesn't make sense. It's a condition that terminates spontaneously, and yet we choose to do a treatment for that.
So as a doctor you could choose to wait for spontaneous cardioversion?
Yeah, and that was the idea behind this trial, that it would be better to wait for a few hours to give the patient the opportunity to terminate its episode spontaneously and wait and see what happens.
And now Nikki, how did we design the trial? What was the design of the trial?
Well, our hypothesis was that a wait and see strategy, including weight control for symptom relief, and then a 48 hours visit to control the rhythm, was non-inferior to the acute cardioversion for patients.
Right. And what was the endpoint in the study?
Well, the primary endpoint was the rhythm at 4 weeks.
Okay. Elton, why did we choose 4 weeks? That doesn't make sense because patients come in acutely and then you want to know right after.
Yeah, so it does make sense because almost every patient leaves the hospital in sinus rhythm either during the first visit to the emergency department or after 48 hours. So we needed an endpoint that would check for complications of this new approach. And that was the 1 month visit to check whether we left more patients in atrial fibrillation, whether they had more recurrences or longer episodes.
So in fact it's necessary to know also what happens after the acute event of the attack of AF, and that's why we looked for 1 month. Thank you. Now, was it effective? Was the wait and see as good as the acute cardioversion, Nikki?
Yeah, of primary endpoint after 4 weeks was similar for both groups. It was 91% in the wait and see approach versus 94% in the acute cardioversion group. So those numbers in sinus rhythm are similar after 1 month. But most interesting is that our hypothesis is of course that patients in the wait and see group had spontaneous conversion. And we saw that in almost 70% of the patients spontaneously had sinus rhythm within 48 hours. So I think it was very successful.
Yes, and it really also fitted with our idea of how things would happen. Did we see complications, Elton?
No. Ja, wat gaan we daarover zeggen?
And there were only a few complications. And
Did we see complications, Nikki?
There were only a few complications, but similar in both groups. The immediate complications, so during the index visit, were 3 for the wait and see group and also 3 for the acute cardioversion group. And in the long term, so within a month, also the complication rate was similar between the groups.
Okay, thank you. Elton, was the wait and see safe enough?
Yeah, so in both groups there are very low complication rates. So both approaches are safe. We don't see any signs that one approach would be safer than the other. No.
And could you elaborate a bit on the costs? What do you think, whether it's cost effective or not?
Well, we don't know for sure yet because we haven't done those calculations yet, but we do see that the index visit, so the time spent in the emergency department, is significantly lower in the wait and see group. So we do expect a reduction in costs, and we don't see any effect on recurrent visits and such. So we do think that the wait and see approach is more cost effective than the acute cardioversion approach.
So Nikki, the duration of the index visit was shorter in the wait and see group. How does that come?
That's correct. Yeah, of course, if patients need to undergo an acute cardioversion, it's mostly or pharmacological with flycanide or electrical cardioversion, and that requires time for the anesthesiologist to come and sedation and also the observation period after the cardioversion, and all that together it takes longer than just rate control and wait and see.
So the wait and see strategy costs less time than the acute cardioversion, and that has to do with the fact that the wait and see patients can be sent home right after you have installed rate control, whereas in the acute cardioversion group you have to wait for the anesthesiologist, the patient must be fasting, and you're rescheduled because you're not an acute patient anymore. What are the implications for clinical practice, Elton?
We do think that these are two options to be discussed with the patient. They're both safe, they're both effective, but we do think that many more patients will choose for a wait and see approach. So we expect to reduce the burden on the emergency department, to reduce the number of visits even maybe, because if patients know that their attacks terminate spontaneously, they may wait at home. So we expect to reduce the burden on the emergency department and thereby increase the quality of life of the patients involved.
Nikki, what do you think are the implications for clinical practice?
Well, I agree with my colleague, but I think also we can avoid acute cardioversion in the future.
Nikki, the design of the trial, could you elucidate a bit?
Yes, we performed a multi-center randomized control trial in 15 centers in the Netherlands, and in total we included 437 patients with paroxysmal atrial fibrillation. And our hypothesis was that a wait and see approach was non-inferior to the acute cardioversion, with our primary endpoint sinus rhythm after 4 weeks of inclusion.
And are we planning further studies, Elton?
Yeah, we are currently designing a next trial in this field, also a multi-center trial within the Netherlands.